Welcome to the UNLV School of Public Health. We're very excited today to present to you a seminar series talking about the coronavirus and its impact here on our community and internationally. I could not be more thrilled to have two of our esteemed faculty members here to present this topic to you today. And first up will be Dr. Brian Labus. Brian did his MPH at Berkeley University and did his PhD right here at UNLV School of Public Health. He was also a senior epidemiologist at the Southern Nevada Health District and played instrumental roles with respect to the SARS outbreak as well as the hepatitis outbreak that impact us here locally. Second, I have Dr. Francisco C. Francisco comes to us from Harvard and Hopkins, where he was formally trained. He was also a member of CDC's SARS outbreak investigation team back in 2003. So we have two wonderful experts today. I hope you enjoy the seminar and you learn a great deal about this important issue.
Chair here. On behalf of our Dean, Sean Rosenberger, I'd like to welcome you all to our seminar on responding to the coronavirus COVID-19 epidemic, lessons learned from SARS and a look into the future. So in 2003, when SARS outbreak occurred in China, in the US, and other parts of the world, Dr. Labus and I were both involved in the response to it. At that time, I was working at CDC, so I was part of the CDC outbreak investigation team. And Dr. Labus is an epidemiologist working here at Southern Nevada Health District. So as infectious epidemiologists, we were both involved in this, in the SARS outbreak in 2003. And I want to share with you our information about the COVID-19 and also what the lessons we learned from 2003 with SARS. And the important thing here is not to panic. Make sure that you go on with your life, business as usual, just increase your infection control practices. The risk is no risk or very, very low risk at this point in time here in our state. So Brian will go first. We're going to talk about the epidemic in the US and the epidemic worldwide, and then I follow and talk about other things related to SARS. So Brian.
Thank you, Dr. C. So in 2003, I was at the Southern Nevada Health District, and the first case we had in Nevada was a long-haul truck driver who basically was coming back from Montreal, the first person we investigated. Just the routine kind of stuff that we would do. The next case I thought would be the paper that would make my career. So we had somebody who was diagnosed, he was a doctor who worked at a hospital in Hong Kong that was seeing SARS patients. He wasn't treating them himself, but he was working at that hospital. So that put him at an elevated risk. So they were testing everybody before they left the country, and he was coming to the US on vacation. So he tested weak positive. And they said, oh, we need to retest you then, because we're not sure exactly what that means. They retested him, but before the results were back, he got on a plane to the US, landed in San Francisco, and then got on a tour bus and went to LA and then to Las Vegas. And we caught up with them as the tour group headed to the Hoover Dam, but the hospital got in touch with them and said, we have this weak positive result still, please don't go with them. So I got to go to the room and actually sit there with somebody who potentially had SARS and interview them and find out what's going on. And so we thought, well, this person's asymptomatic. We had a group of people who have been with him every single minute for 2 or 3 days. This is an amazing study on asymptomatic transmission of SARS. So we set things up so that the bus would pull up to the front of the health district. They'd come inside. We'd do blood draws. CDC came out to assist us. We had this whole plan. They contacted them at dinner, and the bus driver said, no, I got paid to take him to the Grand Canyon and home. I'm not doing anything else. I'm done with it. So we packed up everything, went to one of the hotels in town. I was interviewing patients on the bed. They were doing blood draws in the bathroom. They were doing fever screens in the hall. And we did this amazing study. So I thought this is going to be first paper in Science or Nature or something like that. Well, the weak positive was actually a false positive and turned out not to be anything. So I got to do all this work on SARS, but it was actually all this work on somebody who didn't have anything. But I want to talk about what's going on right now. And one of the important things to think about in an outbreak like this is to really know the story of what's going on from the perspective of the data. It's not just about what's in the news, it's about what the numbers are telling us about what's happening in the outbreak. Now, this is the clinical presentation of disease. So if you look at what the patients are seeing right now, fever is the main symptom, almost 90%. Dry cough is the other one. So those are the big things that they're looking for. And that's great because it's just like flu and everything else that's circulating right now. And that's one of the huge challenges with diagnosing this. If people are showing up in the emergency room right now, they have a disease with upper respiratory symptoms. And there's all sorts of things with upper respiratory symptoms. So even if you're in China, where the outbreak is happening, you can't be certain that it's coronavirus. It could just easily be flu. So we see a lot of different kind of clinical symptoms. And this is similar to what we saw in SARS and MERS and things like that. A respiratory illness. 81% of the cases that they've seen, this was out of the first 44,000 cases of the ones they saw in Wuhan. Roughly 80% of the people, 4 out of every 5, have a mild disease that really doesn't require any sort of treatment or anything like that. 14% of those were severe cases, 5% were the critical cases. And those were more common among people who were older and had underlying health problems. So we're seeing the most severe disease in the people at highest risk. So that's not really surprising. When I talk about people at the extremes of age with underlying health conditions being the ones that get this disease, people get mad because they say, well, you don't care about old people. Well, it's not that I don't care about old people. The people that are getting really sick are the ones that we would expect to get really sick. So it's not that I don't care, but the disease is kind of progressing the way you would expect it to in a population. We're not seeing otherwise young, healthy people infected to the point where they wind up in the ICU. This is looking at the way they classified their cases. And so as an epidemiologist, I would group these a little differently. They have confirmed cases, which require a lab confirmation. They have probable cases. These are people with the disease who have a strong epidemiologic link to somebody else. So they were working with people, lived with somebody. They had a direct connection to somebody with coronavirus. And then there were these other 10,000 cases that are suspect cases. And this is where things start to get a little bit hairy when looking at the numbers coming from China. They've used a number of different case definitions over the course of the outbreak. That happens. That's not unexpected. But at one point, they expanded the definition so anybody with respiratory disease was now counted as coronavirus. And then they kind of dragged that back and said, well, that's probably a bit too much. They were just using that in Wuhan. Well, of course, the numbers are going to spike as soon as you broaden the definition. And then when you narrow the definition, they're going to go back down. So in China, when they're talking about, there was this huge increase in cases. Yeah, because you count them differently. Hey, we got it under control. There was a big decrease in cases. Yes, because you're counting them differently. So that's why you have to be a little careful with the numbers that are there. This is the way Johns Hopkins is showing it as of last night. I didn't want to do this live because I figured it would crash as soon as I tried to. They have a really cool map that shows where the cases are, total confirmed, total deaths, total recovered. This is a little bit tricky to understand, though, because if you're looking at the cases coming out every day, it's how many are being reported. You don't know exactly when those cases occurred, especially from the data like this. So early projections were all based on when those cases got reported. So if 100 people got sick today, but it took me 3 or 4 days to find them, my case count's going to look like it's constantly going up, even though everybody got sick on one day and it was flat, and then you get some hedge fund manager taking the numbers and making a projection that 2.5 billion people are going to get sick in the next 3 weeks or something like that. So there was a lot of misunderstanding based on the data. You really have to understand what these things mean, but we know that it's all over the place right now. It's not being seen just in China, although Wuhan still has way more cases than everywhere else. We're seeing it throughout the rest of the world. That means there's local transmission everywhere. The idea that you could try and contain this in one place right now is kind of absurd, because if that would have worked, we wouldn't be seeing this exact spread. So we're seeing disease everywhere right now, which means as it's popping up in communities, those are not the first people to get the disease. Those are the first ones we identify. So we had that first case in southern Nevada. They got it from somewhere. We have the second case. They got it from somewhere and it wasn't from each other. So we know there's a background amount of transmission actually going on. Now, trying to compare SARS, MERS, and this current coronavirus, these are the 3 coronaviruses we've dealt with most recently. Now, there's 4 other ones that routinely cause disease in a human population, but they cause the common cold. So we don't worry about those. They're completely different. With SARS, that was the first one we dealt with. We had just over 8,000 cases, 774 deaths, and a 9.6% death rate. It was a pretty high death rate, but it didn't spread very far beyond the few places where we really had a lot of transmission. We had a few cases in the US, but not anything like we're seeing right now. MERS was very different. MERS is still going on. There's 2,500 cases, and almost 900 of those people have died. But those are people that were the primary cases. They had direct exposure to camels in most cases. We're seeing it go through that animal. It's usually bats to something, to humans, and MERS, it's camels. SARS was civet cats. This one, will be some other animal probably in the middle. We're not sure exactly what yet. That one has a very, very high death rate, but it doesn't spread very easily. It's just kind of been bubbling along in the background. People stop paying attention to it, but it hasn't gone away. Now, the one we're dealing with now has a 3.5% death rate if you do that calculation. That's also completely overblown, and I'll explain why in a second. So the problem with all these numbers is that the numbers themselves lie. Unless you know exactly what they mean, you get a completely skewed view of what's happening with this outbreak. So this is the case fatality rate starting at January, the beginning of January, and going through the middle of February. And you can see that case fatality rate drop off over time. Well, why would that happen? It should be the same death rate across the outbreak. It shouldn't change too much. You're learning how to treat it, so that's going to be part of it. But really it comes down to early on in an outbreak, you're testing the sickest people. So if the only people I'm testing are people in the ICU, of course I'm going to find a really high death rate because I'm only testing people about to die. So it makes sense that the death rates early on are really high. We saw that in 2009 with influenza. The reports from Mexico were 90 to 100% death rate for this new flu strain. Well, it was actually about 0.1%, but they were testing people in the ICU with severe breathing problems. So of course they found this really high death rate. They also don't include all the people at the really mild level of disease who don't get counted in the first place. Now, this is the way the World Health Organization described it in their report, which I think is really important to look at. They basically said the death rate was very high in Wuhan and other places, but in other areas of China, it's at 0.7%, which is probably a much more realistic estimate of what's going on. Another challenge we had early on was one of the outbreaks that happened in Wuhan was at the hospital. So the patients came in sick and they infected a bunch of other patients who were there for heart surgery and chemotherapy and things like that. So they were very high-risk patients to begin with. It was really skewed. But what we're seeing is a much lower death rate, 0.7%, and that makes sense. It's probably even still high as we start to include those mild cases that aren't being counted. As we test lots and lots of people in the community, that death rate's going to go down because the numerator's staying the same, the denominator's just getting a lot bigger, so that death rate is really going to decrease. We also see big differences by age. So we tend to categorize and say, overall, here's what the death rate is. But if you look at people under 50, the death rate is pretty low. In the youngest age groups there, even assuming this is correct and not overstated, that would basically be a really bad flu season. Flu itself is about 0.1% or a little higher. So it'd be a really nasty flu in young people, but not a zombie apocalypse movie, basically. When you get to people over 80, that's when you start to see really serious problems in a lot more people and a much higher death rate, which is not surprising because they have weaker immune systems and a lot of underlying health conditions. So this is really the problem. When you put a pyramid up like this, the bottom line on their chart said cases that were not identified and not diagnosed, but it's probably like that or a lot bigger. So what you're getting is a really skewed view and saying, yeah, 5% are critical cases of the ones we know about. So everything winds up being quite a bit skewed when we really try to look at all the data that's here. This is the outbreak curve that was in the report, this was in the JAMA publication that they put out, looking at what happened in Wuhan by itself. There were almost 45,000 cases on this outbreak curve. And to me, this just doesn't look right. And I can't say exactly why, but it looks too perfect. I would not expect to see this sort of thing happen, and I'll come back to why this may be the issue in a second. But this is the curve that they showed. We're seeing cases pop up all over the world, but this is the way they basically described their outbreak. There's also this weird thing on February 1st. I couldn't figure out why there was a spike, but there were a lot of people that apparently got sick on that day, and it doesn't really make sense why unless there was some sort of event at a hospital, something like that, that infected a few more thousand people that day. So I'm always suspicious of the numbers I see. And then when you look at this chart, this is looking at Wuhan outside of Hubei, and then or Hubei outside of Wuhan, and then China throughout the rest of the country. So you can still see that big spike that was there on the 1st of February. You see that same little bit of a spike nearby, but then you see this spike throughout the rest of China. So what event happened that everybody got sick all at once in multiple places in the country? So it could be something as simple as a case definition change or the way they counted things, or there could be another more nefarious region for it. This is a problem we have with data coming from China. Now, they were criticized heavily when SARS happened. The same criticisms haven't been there through this particular outbreak. The criticisms during SARS is that they weren't sharing the information, they didn't respond fast enough, they basically tried to cover it up. We haven't seen the same sort of thing here, but when you're dealing with a government that does control all the information, you have to wonder how accurate are the numbers that are out there. So understanding what those things really mean is difficult. The outbreak curve doesn't make a lot of sense to me. There's just some things going on that make it interesting, but you really have to question all the numbers. Even assuming everything's true, you still have to question the numbers. But then we start to get these political pieces into it, and you have to wonder really what's going on with the exact counts and things like that. All right, this is one that you've all watched on the news over the past couple weeks. It's odd. My Facebook friends who were constitutional scholars just a month ago are now infectious disease experts. I don't post a lot of stuff on Facebook and reply to people because it drives me insane, and I'd wind up just angry and swearing at a lot of my friends. So, but you've all seen this sort of thing, and stuff starts to pop up, and you know how people are reacting to something like this. Well, this isn't new. These are the type of cartoons we saw when SARS happened almost 20 years ago. The exact same types of panic. People freaked out because it's a new disease. It's something different. It's something people haven't seen before. And with that uncertainty comes a lot of fear, and people start to do really strange things when they're scared. So we've seen this sort of thing. Oh, wait, that was SARS in 2003. Okay, so it's more like this. Well, no, that was actually a flu outbreak in 2009. How about this? Oh, that was plague in India in the 90s. Same sort of thing. You could see this is today. Well, nope, that was MERS in 2015 in South Korea. This looks like the same thing we're doing right now, but that was how people responded to Ebola. So there seems to be this common thread of buying masks and freaking out no matter what the disease is. So you've seen these sort of pictures. They make great stories on the news, but the masks themselves are basically useless. The masks you can find here, the ones you see them wearing, are all surgical masks or dust masks. If you go to Home Depot and buy them off the shelf, they're masks that are really good at taking chunks of drywall out of the air before you breathe them in doing a home renovation project, but viruses are small enough that they're going to go right through these masks. So everybody's buying up the masks and then wearing them improperly. So even if they had the right masks, which they don't, they're wearing them all day, pulling them off with their hands, putting them in their back pocket. Well, anything the mask would have filtered out is now all over your hand. So we worried about this with Ebola. The way people put the protective gear on and took it off was a huge concern. And so they actually would take their masks off with other people assisting them and viewing it to make sure they didn't contaminate themselves. It's not as simple as pulling the mask off. You have to do it in a way that's not going to contaminate your hands and your face when you take it off, because otherwise all you've done is concentrate all that virus, and then as soon as you take it off, you breathe it right in or get it in your nose or whatever. So the CDC put out this guide to hairstyles. I thought I had a goatee. Apparently I have a circle beard according to the CDC, but that's all right. I did see one headline that was saying the CDC is now recommending these facial hairstyles. Well, no, they're not recommending anything. They were talking about all the different types of hairstyles that are out there and how it can affect the fit of a mask. So when I got fit tested at the health district, they said, well, your facial hair may get in the way. And I said, if there's an emergency, I have no problem shaving it off. I'm not that attached to my facial hair that I'm willing to put my life on the line. But depending, if you have a full beard, you can't get a mask that's going to seal properly on the sides of your face. And that's the other problem with those N95 masks. Even if you can get them, you have to be fit tested so the air doesn't leak in the sides. And if you've gone through the fit testing, it feels like it's perfect on your face, but there's still air getting in through the sides because they can measure that sort of thing. And then, of course, we see things like this. I don't quite understand why people have decided that the appropriate response to a respiratory disease is to buy all the toilet paper in the United States. I don't know why they're doing it. I don't know what this is going to do. It's a panic buying sort of approach. We've seen in other things before. It happened with SARS and some other outbreaks. People just think it's an emergency and I need to stock up on toilet paper. I did see one story about a family in Australia who was trying to buy a 48 pack of toilet paper. They bought 48 boxes of toilet paper, so now they have enough for the next 10 years. People have freaked out, though, and this is one of the ways it's manifested itself. Lines for toilet paper and water at Sam's and Costco. I don't know why they're doing those things, but maybe part of the idea that doing something is better than nothing. Now, the CDC is constantly putting out information about this outbreak, and this winds up being one of the biggest challenges that the people on the public health side have to deal with, and then how do they translate that to the public? Because the information changes constantly. The guidance changes constantly. By the time you put out a fact sheet or a poster that says, here's what you're supposed to do, what you're supposed to do has changed. And that's been a huge headache over the past, well, pretty much every outbreak that I've ever worked with. So the most recent things, they changed the testing procedures. So we had a testing procedure in place where it was based on what country you went to, and then that was kind of pulled back, and now everybody can get tested, but you still have to go through your doctor. This changes every single day. So getting this information to the public correctly has been a giant challenge. We're never going to solve that one because as the outbreak progresses, we learn more about it. Our recommendations change, so of course we're going to change what we're saying to the public. Now, when these things happen, another thing that happen with any outbreak or any problem is that rumors abound. There are all sorts of things all over social media. There are all kinds of cures. I had to put out stories that said weed does not kill coronavirus, cocaine does not kill coronavirus, eating garlic does it, vitamin C doesn't do it, all these things. Even the president said, well, you could take a solid flu vaccine. Couldn't you just use that for coronavirus? There are all these weird stories about how to protect yourself because people don't know what else to do. And it seems like the people with the worst ideas are the ones speaking the most and the loudest a lot of times, especially on social media. Everybody's demanding that we do something about it. So we're producing a vaccine. And of course, when that comes out, it'll be the government plot to control your brain or whatever. So these are the challenges we face with every single outbreak. We know what's going to happen. It's not a surprise. And so we try to counter this with good information and get out in advance of these things. People have been recommending like gargling bleach. Well, yes, that'll be effective. It'll kill you as well, but it will kill the virus probably. We just don't want people getting that information from a reputable source being retweeted by a senator or something like that. That's happened in this particular situation. But this is a huge challenge of how do you control these incorrect messages and make sure the correct information is always out there. The final important lesson is that public health works. In 2003, we didn't have a vaccine, we didn't have a treatment, we didn't even have a test early on. It took a lot longer to develop a test, but the basic public health approaches that we take to an unknown disease worked to help control SARS. So on the left, we have posters that were up for SARS, things like don't spit, don't sneeze at others, wash your hands often. We're recommending the same sort of things today. Basically keeping the virus off of your hands, distancing yourself from other people, and trying to prevent yourself from either infecting others if you're sick or being too close to sick people. Those sort of things work really well. Quarantines actually work to slow down or stop the transmission of disease. The reason the quarantine didn't work so well in this case is because we had a lot of spread before we even realized it, so we were trying to quarantine people when it was a little bit too late. The next thing you're going to hear about is social distancing. The idea of social distancing is you're not stopping the outbreak in its tracks, you're not reducing the number of cases, but you're spreading them out over a much longer period of time. So the same number of people get sick, you may have the same number of deaths, but if we have a bunch of people get sick in one day versus 1 month, the hospitals get completely overwhelmed. It's kind of like if you're going to get a foot of rain. I would rather have it occur over 2 weeks than in one afternoon because our system can handle it if it's over a longer period of time. If it happens all at once, that's when the system collapses and there'll be a lot more deaths because we can't treat people with this particular condition. This is the next step. This is what we'll see next, and this is where we're talking about school closures and people going home from work and concerts and all those sort of things. Those are decisions we'll have to make as a community, the best way to do this without completely disrupting everything that's going on. Do we even need them? Can our system handle the number of cases? Well, we don't know until we actually start to see the transmission occur and get an idea of how many cases there are. The other thing we talk about is non-pharmaceutical interventions, which just means all the things you can do that aren't medicines. So avoid handshakes and cancel meetings that shouldn't have happened in the first place, and eat your lunch at your desk instead of with all your friends together. Things like that, just to keep yourself a bit away from other people. This will be one of the buzzwords you hear, NPI, or non-pharmaceutical interventions, over the next couple months as we deal with this sort of thing. These sort of things worked with SARS, and they can work again with this, so we actually have something we can do because public health does work. So with that, I will turn it back over to Dr. C for the next part. Yeah, I got you.
Put this. I can't see. So Brian showed you all the different masks. You can see here the mask they use in the plague in the Middle Ages, and then this is what we have for Ebola. There's a modern outfit, and So why does this disease emerge? So in 1992, the Institute of Medicine came up with 6 factors. If you look at the left side here, you can see that the first one there is microbial adaptation and change. But if you look at the rest, from economic development, human demographics, behavior, international travel, technology, breakdown public health measure, all of them are human-driven activities, right? So of all these 6 factors, only one refers to the microbes, how the microbes adapt, how the microbes mutate. But the rest are all human-driven due to our behavior. So this can change. So these are all within our control to handle this crisis. So if you look at and then in 2003, the Institute of Medicine convened again the experts, and they came back with the same, the top 6, plus they added additional factors like increased human susceptibility because of treatment that we have for immunosuppression, for example, for cancer. This increased their susceptibility. Change in weather, climate change affect the ecosystems, and then of course living social determinants of health, poverty, social inequality, war. You can see all the refugees streaming from Syria to Greece and then being turned away. You can see countries that don't have political will to deal with the epidemic or with political problems, and some people have intent to harm. So you can see that all these other factors play a role in the emergence of disease. So there's a lot of factors. I think for SARS and for COVID-19, you can see international travel play a lot of a role from plane or from cruise ship and other things. You can see that all of this play a role. And then if you look at the typical agent, host, and environment, you look at what would drive a human and microbes together. In the past, we learned in our epidemiology that you have the agent, host, and the environment. Right? From those emerging factors that we discussed earlier, you can see that factors are very broad. It's not just physical factors or environmental factors. You can also look at genetic and biological factors of humans that make them more susceptible. You can look at ecological factors, the climate, the social conditions of people, and political economic factors. So all these different factors could converge and force humans and microbes together to cause disease to occur or the epidemic to occur. So spread of disease, you can see that we talk about outbreak. We're in the middle of outbreak right now because there is COVID-19 that occurs in different parts of the world. And remember way back about malaria and other things, they're more endemic because those, they occur in a steady rate in different populations of the world. And then epidemic is when it's spread to larger geographic area. And then pandemic is when it's globally. So I think we're now in the midst of a COVID-19 pandemic, which is all over the world. So I want to share with you my experience working with SARS in 2003. So around February 2003, that time I was working in Division of HIV/AIDS at CDC. And then the CDC director sent an email to everybody. And the criteria are, if you know something about infectious disease, you know something about epidemiology, and if you, preferably also if you know some Asian language, we need you badly to go to Asia and help with the outbreak investigation going on in Hong Kong and China. So I sent my background information. In 2 minutes right away, the coordinator said, Dr. C, where do you want to go? Vietnam, Hong Kong, China, Taiwan? My answer is none of the above. And because at that time, the same thing was happening, the panic buying, people wearing masks, all this fear is so great. But all my colleagues were excited. They want to travel. They want to I live half of my life in the Philippines. I've traveled a bit to Hong Kong and China, but I've seen the other part of the world already. So it's not as exciting. But for my other colleagues who are epidemiologists, oh wow, that's a chance to go to the field and go out. But at that time, I was working with HIV/AIDS, and I was in charge of the community outreach effort in my branch. So I've been already coordinating with different community-based organizations in different parts of the country, including Asian group and Latino group and African American group. So I already have inroads working with the different population. So what I did is I said, when we established the Outbreak investigation team, we met twice a day, 7 a.m. and 7 p.m. because 7 a.m. here is 7 p.m. in Asia, and 7 p.m. is 7 a.m. So twice a day we would meet, and they talk about the update, but I'm more concerned with the fear. So I said, I'd rather organize a community outreach team and work with the fear, because as an Asian, I felt like the fear is so great, and the discrimination against Asian, especially Chinese, so great, and we need to do something about this. So that's what we did. We would go to different parts of the U.S., from Chinatown to Chinatown, and to different places where Chinese convene. And then immediately after each of my presentations, there'll be newspaper coverage saying, this says, CDC said SARS is not a Chinese disease, because at that time, people had misconception that, if you look Chinese or Asian, you must have SARS. People stay away from you. And as Brian mentioned, all the businesses went down in different Chinatown, to the point that even Hillary Clinton had to go to Chinatown in New York and eat there. And the next day, there's a picture of her in the newspaper. New York Times shows her eating. I'm eating in Chinatown. I didn't get SARS, right? So and then we work on that paper, and then we wrote up a paper and we published it here. It's called Fear and Stigma, the Epidemic Within SARS Outbreak. So actually within the SARS outbreak itself, there's so much fear, and there's so much epidemic of fear going on. And we talk about how we dealt with it. So one thing we did at that time was whatever information we have about SARS, immediately would translate it into different languages, Asian languages. And it turned out that in times like this, in epidemic situation, the normal procedure is that you need to do 3 bids to get a government contract to translate for translation. But in times like this, you can bypass that. So what I did, I'll go to the cafeteria, and then I have the basic information in a piece of paper, and I would go around and I would approach somebody and said, "Oh, are you Korean?" They said, "No, I'm Vietnamese." "Oh, could you translate this into Vietnamese?" And then I'll ask somebody else to back translate it. And the same thing is true. I'll go around and ask somebody, "Are you Korean or Chinese?" So in one afternoon, just go to the cafeteria, I was able to approach different employees to help me translate the basic information about SARS, so that next day we could put it up in the website right away. So you can have all the basic information in different Asian languages, because so that the affected communities also understand what's going on. Because even among Chinese themselves, the fear is so great, because they watch the satellite TV and they look what's going on in China, and they think that's also happening in the U.S. But actually, at that time, the U.S., most of the cases were people who traveled to Asia who return. At that time, there's no local transmission yet. If there's local transmission, a lot of them are very limited in numbers. I can share with you the article that we wrote, and if you're interested in this. So what is coronavirus? Coronavirus actually has been around since 1960s, okay? And there are 4 types of coronavirus, from alpha, beta, gamma, and delta. And the one that we're dealing with are beta coronavirus, including MERS, the Middle Eastern Respiratory Syndrome, MERS, or SARS. And the SARS that we dealt with in 2003 is called SARS coronavirus 1. The one that we're dealing now with COVID-19 is SARS coronavirus number 2. So they're all beta coronavirus. So actually it's a zoonotic disease. So it's a disease of animals. So there's actually this is going on among the animal population. When human invades the animal's population, they get the infection and become a human-to-human disease. So their reservoir is really in the animals, especially the bats. So coronavirus will be occurring again in the future because you cannot control the animal population. So you can see that these are the other animals affected by by SARS, like monkeys. This is civets, cat-like intermediate host, but there are other types of animals affected. With MERS, the intermediate host was a camel. So SARS coronavirus is a RNA virus, and you can see it's called corona because all the spikes come like a crown. All the spikes are needed, and they need all these different spikes because if you look at the life cycle, when they invade the cell, the respiratory cell, they need that to enter the cells and invade it. And once they invade the cell, they multiply inside the cell. Okay? I'm not going to the detail of it, but I just want to show you there's a life cycle. They invade the cell, they multiply, they shed more virus and become more infectious to other people. And this the emergence of SARS and MERS. You can see this is how the civet look like for SARS, and this is a camel for MERS. And you can see that actually it's a zoonotic transmission. It's a zoonosis. It's a disease of animal transmitted to humans. And once it's got into human, it could be human-human transmission. But you can see the reservoirs are here. This is the reservoir of coronavirus, the bats. So it's really hard to control this. If you invade the bat population, you get the transmission from animal to human. This is just a sequence of events that happened with SARS in 2003. Actually started also in China, in southern part of China. But you can see that because of the collaboration of different organizations, you can see that WHO got involved. And then by 2003, in a matter of 8 months, we're able to contain the epidemic, right? And what we did is through infection control. Infection control, improvement in infection control, quarantine, in isolation of cases. There's no antiviral treatment, there's no vaccine for it, but it was just infection control practices. And then MERS started in 2012. It's still ongoing now, and I didn't update this, but Brian gave you the latest case of MERS. And with MERS, Korea is also involved because of the people working in the Middle East returning back to Korea, and then they were hospitalized in hospitals in Korea, and that's why there's a big spread of MERS in South Korea in 2015. It's more nosocomial or hospital-acquired infection. So if you look at infectivity, during the incubation period for the SARS or for the COVID-19, the incubation period is actually 5 days to 14 days. So that's the time for exposure to the time you get the infection is about 14 days. And the infectivity of the person is really very low at the time. Then you develop your fever and cough, very nonspecific, but that's prodromal symptoms, 1 to 2 days. Still very low infectivity. And then when you start coughing and they have hardness in breathing already and onward, you can see that that person becomes very, very infectious. Those patients are the ones that's being hospitalized, isolated, being quarantined. And most of them recovered. Only 10% developed acute respiratory syndrome. One thing that's not happening now that happened in SARS is the role of super spreader. So right now for the COVID-19, for each case probably there are 3 to 5 cases that were infected from a patient. But then for SARS, there may be fewer cases, but actually there are more people who are called the super spreaders. And one person can transmit to about 36 people. And it's hard to understand it, but it could be due to the viral load of the super spreader. And I want to show you the slide that shows that, for example, this is patient number 1. You can see from patient number 1 how many more cases got infected from that person. Look at patient number 6, spread to this person, and this one is spread to more people here. So you can see, and this happened with SARS, but it's not happening with COVID-19. It's very different. The behavior patterns seem to be very different. And then, so what do they tell you? That you should wash your hands, don't touch your face and your mouth. This is the reason, because you can see how close our mouth and our nose and our eyes are from each other. There's this nasolacrimal duct, how close they are. So that's why they tell you to wear your mask properly, make sure that you wash your hands and don't touch your face, because this how close they are. And also there's the respiratory viruses, some of them have ocular tropism. They may also grow in the tear, the eye area or the nose, and that would be the point of entry. Could also be the point of exit for like this respiratory viruses. And these are diagnostic assay for treatment, for diagnosis. So that even with COVID-19, they're using this rapid, real-time reverse transcriptase polymerase chain reaction test as an initial test that they do, right? And then you can also do antibody tests, looking for the antibody to these different microbes. And there are other assays which is hard to do, like culture, electron microscopy. They're more need a higher laboratory to do this kind of thing. But the easiest is to do the PCR, rapid transcriptase test. So the other thing that Brian mentioned is the reaction to people with COVID 2019. You can see that as coronavirus spreads, so does anti-Chinese sentiment increases. This in Korea, calling for a ban on Chinese visitors. This a nail shop in Vietnam saying, sorry, we don't accept Chinese customer for coronavirus. Thank you for understanding. This a restaurant in South Korea, Hong Kong, Vietnam. They're not accepting Chinese customers. Do not accept guests from China. No, and for people like me who's Filipino but look Chinese, they think, eventually I'll be affected too, because Asian look, they think that all Asians look like Chinese. And this in Hong Kong, where they're asking for tighter control of the borders with mainland China. They're saying, close the border and say no to China. And the same thing that Brian showed earlier, this is how French Asians are reacting to all this anti-Chinese racism. They're saying, I'm not a virus. So the responses that Brian mentioned earlier is, our community response should be based on number of cases, exposure category. Right now, our risk is none to low. We have not traveled. We're here all the time. We may congregate here, but none of us probably have history of travel to Asia or to all those other places where the high risk. We did not been to a boat cruise. So our risk is very low. So there should be no restriction, no restriction, no closure. And then if there is some, then it could have some kind of, I think we should empower ourselves. If we think we're sick, we should stay home, right? And we should not be closing public places. But if there is increase in cases, then you might have to do all these other things, suspend public gathering or canceling conferences. But right now, none of those are happening here in Las Vegas, so we should not be doing these more drastic draconian measures. So basically, the way we dealt with SARS is infection control practices, and then if we find a case, we isolate them and treat them. and then we quarantine patients. So improvement in basic control practices is very, very important. And this is a timeline comparing the two. You can see that with SARS in 2002, November 16th, the first case, and by July 5, WHO declared that it has been contained. So in 8 months' time, I think it's the right disease that occurred at the right time where there's a collaboration with WHO, CDC, and China and other countries, and the scientists too. They're able to identify the virus in April. By July, they're able to contain it. But if you look at COVID-19, it's still evolving. This is a JAMA article published in February, so it's still we're just at the beginning of the epidemic here, so we haven't seen the end here. This is February. So lesson learned from SARS is transmission occurs through close interaction with infected person. Okay. Persons with unrecognized SARS can contribute to initiation and expansion of outbreaks, especially healthcare setting. This is the hospital-acquired infections. SARS in a single healthcare facility can have far-reaching public health effects, as shown in that, for example, that nursing homes. Healthcare workers are affected because of their close contact with cases, so they need to have protection. So infection control is the primary interventions that we need to do. And then if you have cases, you need to isolate them and quarantine them. And then patients with mild SARS can be safely isolated in locations other than acute care facilities, which is really need to be for people that are very, very sick. That's the end of it. Any questions? I think for both Brian and I are available for question and answer, and you can also share with us your own experience in what's happening then in 2003 and what's happening now. Yes.
So, in current events, China has been reported a collapse in cases outside of Wuhan. Do you foresee that happening in the future?
Sure, Mike. I think it's really difficult to say exactly what's going to happen because every time the virus goes into a new community, it's going to be a different situation, different ways that it's spreading. So if you put a bunch of control measures in and it goes away, but you haven't completely gotten rid of it and you get rid of all the control measures, it can easily flare right back up. Kind of like having, say we had a recalled food that was out there and all of a sudden we got halfway to the end and said, we can put it back on the shelves. The outbreak's going to flare right back up. So when you're changing, sometimes it makes sense to change the control measures to respond to what's happening in the community, but if you eliminate them, you can easily see a flare up in any of those places.
Thank you. So from your experience as at today, what's the current case definition for COVID SNHT is using, and how do we differentiate that from flu and common cold?
Well, the case definition has several categories. So the main one is always lab confirmed. So in order for that to count, it has to be a COVID positive laboratory test. It's not just based on the clinical presentation. The clinical presentation alone is enough to start the process of investigating it, but they won't call it a case unless you have a lab confirmation. So right now, basically the recommendation is to test for those other things first. You're going to test for the flu, not for the common cold, but the common cold is probably not going to put you in the hospital either. So really it's ruling out other things and then finding that lab positive. That's more about managing resources, but for it to count, it has to be a confirmed lab positive. So that won't be a problem of getting those other diseases in there.
Just as a follow-up, though, Brian, on the common cold, since among many of the population this virus tends to be mild, is there a need to try to know the extent of some of these other symptoms?
Well, there are panels out there. The doctor from UMC, the infectious disease doc, said they were using the BioFire panel, which has all 4 of the common coronaviruses, all the flu stuff, paraflu. We used to do a surveillance project. There are about 20 different pathogens it covers. So that hits all the main respiratory diseases and gives you an idea of what's going on. At a certain point, though, you have to wonder what's the point of testing. We have a few cases we really want to know. If there's 1,000 cases, then do do you really need to test those people other than, well, they may have flu, so we can treat them for flu. But if there's really nothing we're going to do, we have to manage them as cases. It'll be based on the clinical presentation. They won't count in the overall numbers, but if you've got millions of cases, you're not counting at that point anyway. I was saying yesterday, as an epidemiologist, it's really difficult when there's 1 or 2 cases. There's a lot of work to do. When there's 10,000 cases, it gets really easy because you put a check mark in the column that says sick person and you move on to the next one. And so once the outbreak gets bigger and bigger, then we'll do some things to kind of get an idea of the estimates of the spread in the community, but we're not going to be tracking every single case like we do right now.
Yeah, if you have fever, cough, and flu at this point here in Las Vegas, most likely it's flu. So you should see your doctor or get a flu shots and stay home, because it's highly unlikely that it's due to COVID-19, unless you just returned from Princess cruise ship or somewhere in Asia, or Italy or other places or Korea. But you have no history of travel, it's highly unlikely that it's the coronavirus. Michelle.
What I'm worried about is how it's going to look, and I'm going to ask you to project. I know it's not comfortable. Next winter, so let's say it gets warm and the virus dies down and then roars back again, similar to flu. I guess the question of identifying is, are they going to combine like one flu shot with, or that you have to get 2 separate? And then what will be, like, then will elderly people be sort of, what does the mortality rate look like? Is it going to be 10% more because now it's flu and or COVID-19 that people are going to catch? How does that look? Like,
So flu and coronavirus are 2 different viruses. They're both respiratory virus, but flu is influenza. Influenza undergoes a typical change, because if you remember, influenza goes to antigenic drift, antigenic shift. Very rarely does it go to antigenic shift when it's a major reassortment of genes causing H1N1 big epidemic. Usually it's a minor reassortment, so it's more like antigenic drift. And we're able to predict. Each year we reconstitute our vaccine, because based on our prediction, WHO and CDC experts will sit down together in springtime trying to predict what's coming in winter time. And based on that prediction, they're going to constitute the new vaccine. That's why you need to be vaccinated every new flu season. So flu already seems to be behaving in a more predictable pattern. So we're able to predict what flu would look like in the next season and develop a vaccine for it. But coronavirus, we cannot predict the coronavirus, and there's no vaccine developed for it yet. And the best vaccine we have, there's no magic bullet for coronavirus. The magic bullet is observe infection control practices, stay away from big crowds, isolate yourself if you feel sick. Basically, common sense way of dealing with the epidemic, and 90% of the cases then we recover. Very few cases really become very, very sick.
I would add that there's going to be no coronavirus vaccine for next fall. It's just too short of a timeline. It's easy to produce candidate vaccines, or easier, but then you have to go through the trial process of figuring out, does it actually work? And then you have to roll it out on a scale where it's going to get to everybody. It takes us 6 months to get the flu shot together. We've already made decisions about next year. We're getting that ready for next fall. If everything goes perfectly, we still wouldn't be ready for a vaccine for next fall. But it's hard to say what's going to happen. We really, people want epidemiologists to guess, and we don't like to guess, but for something like this, there is no way to guess. It could die out and we could never see it again. Or it could mutate in some strange way and it's the next zombie apocalypse. There's really, kind of the extremes there, and there's no way to predict what's going to happen. So it's kind of prepare for the worst, but hope for the best, but use the public health measures we have to try and stop it, and then we have to see how the virus responds and then what's next, basically.
Well, your Facebook posts have been amazing.
Thank you.
Sharing them with my friends because they don't believe me.
Oh, people don't believe me either, but that's all right.
I'm a visitor from Touro University, and I'm just wondering if you have, and you weren't with UNLV during the previous outbreaks, but I'm just wondering if there's things that UNLV has taken from the previous outbreaks and how UNLV is response has been compared to the previous outbreaks?
So I can talk about it. I was here in Southern Nevada at least. So I think a lot of what happened between essentially 9/11 and a decade later was a lot of community preparedness. So the difference now is that we've worked together on a bunch of these things. We worked together on SARS and Ebola and multiple flu outbreaks and all those things. I think there's a really strong connection between all of the partners in the community. We're not just working alone or trying to figure out who the other people are when the emergency happens. So I think that's really been the biggest thing there. We do drills now and tabletops and exercises. That's really what we've taken from it. We've learned how to work together. That's probably the biggest thing. Now, when it comes to specific responses, it really comes down to exactly what's happening with the outbreak. SARS really didn't spread in the United States. So there's not much to take from that in terms of how we're responding to this, because we didn't really have to respond to it. We looked at a few cases in Southern Nevada, but it was never a community issue. So we didn't have any practice with SARS itself for this next outbreak.
Yeah, I went to the Dean's Council meeting for our dean because he was not available last week. So the meeting with the deans and the provost, they discussed about what needs to be done. And, I agree. The approach is business as usual, but observe infection control procedure. Make sure that you wash your hands and protect yourselves from exposure. But otherwise, there should be no closure, no cancellation of classes, because the risk is really very low or nothing at all at this point in time. So just because University of Washington is doing it or Harvard, they have more cases there than here. And imagine the impact here on our tourism if you say, oh, UNLV is closing because of, no. I think it's not only based on that, but I think it's based on number of cases. You have 1 or 2 cases. It's just not justifiable to come up with very drastic measures. Niraj?
So, in terms of just containment and mitigation strategies, are there any lessons to be learned the way different countries have approached how to contain and mitigate the effects of this virus? I saw a very intriguing chart yesterday when comparing the trajectory as the caseload has evolved across different countries. And I saw that Japan kind of is evolving very slowly compared to many of the other countries. Is there any specific way that different countries have shows that we can learn lessons from?
We can always learn something from what other countries done, but the challenge is they have different political structures and social structures. So the way you even educate the people about a particular health issue varies quite a bit from country to country. The way people interact with each other, population density, things like that. Japan is an older population, so they're going to approach things differently because they're probably a lot more concerned about those severe outcomes if somebody were to be infected. So we can learn a bit from it, but we don't have the same political structure as China, so we can't lock down a city the same way that they were able to in China. There just isn't a mechanism for that, and you're going to get a very different response from Americans than I think you would from the Chinese if we tried to shut the borders around Las Vegas or something like that, because they're different populations. So we can learn from them in a general sense, but it's really difficult to use specific things.
Kind of on that note, have you heard anything about the really high death rate in Italy? Because it occurred to me that Japan also has a much older population than some of its neighboring countries, but they didn't see that cluster of deaths.
The death rate's really high at the beginning of an outbreak because you test the sickest people. Mm-hmm. Italy is at the beginning of their outbreak. Yeah. Japan has had a slow outbreak going over a longer period of time, so that's going to explain a lot of the difference right there. I wouldn't put too much stock in the numbers until the end of the outbreak, because it's really a skewed picture of what's going on. The testing kits weren't widely available, so we always test the sickest people, just to say, oh, it's here now. And then that's going to skew the death rate.
Yes?
So the majority of the deaths are occurring in the elderly population, especially with underlying implications. But what about children under 5 or infants? We're not really seeing the same numbers.
That's true. We haven't seen those same death rates, and it's not the same disease as flu, so you wouldn't expect it to have the exact same pattern. It's a little surprising not to see high death rates in kids. We're also not seeing a lot of cases in them, so I don't know that we have a great picture of everything. But it's still kind of an evolving thing, and you can only look at it after it's passed and say what that stuff means. So right now it's difficult what to say, other than it's good that it's another population that's not dying at a high rate from the disease.
I think it's because kids are not being exposed. The people who are traveling are mostly elderly. They're going to cruise ships, traveling different parts of the world. So most of the people who are very sick now are people who traveled with history of travel, and they return back to the country. So it's those are the population at risk, especially elderly, and so those are not the very, very young because they're not exposed to the illness.
So we have time for one last question.
Yeah, Jojo.
We heard that the test of COVID-19 is very expensive in the U.S., and even we have a very good health insurance, we still need to pay thousands of dollars. And a rumor, possibly is the truth, California has provided a free test. I don't know about the situation in Nevada. How much would we pay for? Do we have a free test in the near future?
Well, I think it depends why we're testing. So you have to think about the testing for two different reasons. Public health testing to figure out how bad the disease is, look at distribution, try to identify it when it gets here, that's all free. So if any of the testing goes through the health district or the state, that's all free. If it becomes a widely spread disease in the community and people just going to their doctors, it's kind of up to our health insurance and the normal healthcare process to figure out the cost of it, how much insurance is going to reimburse, and all those things. At that point, if it starts to become a financial burden and we decide that the tests are really important for the care of those people, then the state could potentially step in and do some of those things like they did in California and look at the price of it and try to keep it down. But right now it's not available at those commercial labs quite yet. It's just getting to that point. So we haven't had to deal with it yet, but I'm sure that'll be coming soon.
The last question from Sherry.
So for those that are infected, are there any treatments that are working or that are helping the situation?
There have been some reports of different antivirals and things that doctors have tried that are kind of more case studies where they say, we tried this in this one person and it worked, but there is no widespread clinical trial at this point that something's particularly effective. Right now you manage a lot of the underlying, so you get a bacterial infection on top of it, you manage those things. You manage the particular issues the person is having. But like with a lot of these diseases, the only thing you can do is wait until the virus runs its course. So they're looking at those things, but we don't have a treatment for it at this point.
So the treatment, mostly symptomatic treatment for the fever, for the cough, but basically the important thing is to isolate the patients and also quarantine and make sure there's no other additional exposure to that particular patient. Okay, thank you very much for coming.
Thank you.